Dear families from Asia, from Europe, and all over the world, thank you for making your time to join us today. I know this might not be the best time of your day depending on your time zone, but I hope this 1-hour session will be beneficial for you and your loved ones. Before we start our session, there are a couple of housekeeping logistics I would like to remind everyone. If you have not yet downloaded the latest version of Zoom, we will suggest you to do so in case you encounter any technical issues. Today's session is going to be delivered in English. However, there will be a translation available for you in Chinese. So if you want to listen to Chinese, just switch the Chinese at the bottom of the interpreter icon. We have invited the 3 retinoblastoma experts today. They have prepared their short presentation in responding to those questions we collected. Anytime during the webinar, you can continue to leave us any of your questions related to retinoblastoma. At the end of each doctor's speech, we will select a couple of questions that are most frequently raised to have them answered. For all questions left to us, we will collect all of them and get them answered and pushed up in both our website as well as the WeChat official account. Please ensure you check our website and follow our hospital WeChat account. Okay, first, 5 minutes introduction about who we are. Our hospital name is Sant Barcelona Children's Hospital. We are a hospital that has more than 150 years history. Coming from the background as a charitable hospital till about 10 years ago to be one of the reference international center in 2012. We are a children and maternity hospital. We are a non-profit hospital with agreement with Spanish public health system. And we are an university hospital partnering with University of Barcelona. Training, teaching, and providing internship to many medical school graduates every year. As a hospital, we offer complex medical care to pregnant women, to children from fetus to 18 years old teenager. As a university hospital, we offer education and training to professionals. As a research center, we have a large number of PhDs, postdoctors, principal investigators to work on lab, work on mice model with the hope to bring those innovative treatments to clinical trial stage and eventually to be benefit our children. We have currently more than 130 clinical trials actively ongoing in our center. We mainly deal with those complex and rare children disease, and these are some of leading specialties that we have the most international patient reference. Some examples showing those advanced technologies that are available in our center: CAR-T for leukemia, immunotherapy for neuroblastoma, oncologic virus therapy for retinoblastoma. This page is about the article related to today's topic, retinoblastoma, which we published on Science Translational Medicine in the year of 2019 with leading authors from our research center. It is not possible to even give a glance of who we are and what we do in 5 minutes introduction. Please take notes of our hospital website address. And to those Chinese-speaking families, here is our official WeChat account, Hospital SJD Barcelona. It may not have as much information as that one on the website, but hopefully will give you a little idea about us. For any questions, inquiries you have, please drop us email at this email address. Of course, if you are seeking medical treatment proposal, second opinion from our medical team, please scan the first QR code. If you want to seek training, donation, or any kind of collaboration with our center, you can scan the second QR code. Okay, without further ado, let's welcome our first speaker today, Dr. Chantada, who is a worldwide famous hematology and oncology specialist, and will speak about retinoblastoma more from oncologist perspective. Welcome, Doctor.
It's a big pleasure for me to be with you sharing this presentation today. Let me show you my screen just so we can get started. So I just want to give you an overview of the innovative treatments that are available for retinoblastoma. And before going to greater detail, I would like to start with some facts. So when we treat retinoblastoma patients, we usually have two treatment scenarios. There are times, retinoblastoma is a tumor, it's a cancer. So if it is not diagnosed on time, it can put your life in danger, your child's life in danger. So there are two treatment scenarios here. One is when we fight for life of the child. That is when the disease is outside the eye or is at risk of becoming outside the eye. And the second scenario is when we fight for the vision. We are lucky that retinoblastoma most of the times give us the opportunity to save the child life. Most of the times mean more than 90% of the times, depending on the countries you live. But also it gives us the opportunity of fighting for the vision. So the child will not try to lose the eye in the attempt for getting the cure. So this gives us a completely different scenario, because when you fight for life, the risks you take are bigger. So you need to treat the whole body of the child, because the tumor can go to most every part of the body, especially the central nervous system and some bones. However, when your life is not in danger, when you can treat the eye and you are aiming for saving the vision of the child, the disease is limited to the eye. So there is no necessity to give the treatment to the whole body. This is especially important in every child with cancer, but most especially in children with retinoblastoma, because the children that have tumor in both eyes, that is the ones that have bilateral disease, and some patients that have disease in one eye and the other eye is normal, they have a higher chance of having tumors in other tumors not related to retinoblastoma later in life. And these tumors are influenced by the treatment we give. So if we give chemotherapy to the whole body, or if we give radiation to the whole eye, we are perhaps curing the tumor, but in 10, 20, 30 years, we are going to pay the price, because these susceptible kids, now kids, when they become adults, they will have an increased risk of cancer because of the treatment we give. That is when we give the treatment to the whole body, or when we irradiate the eye or the orbit to control the disease. So this is important because when we target the eye, we have many different treatment modalities. These are the treatments that I mentioned that will be more effective to save the vision of your child without causing this impact in the second tumors later in life. So here in this drawing, let me point you here. You see the different modalities for the treatment we give for retinoblastoma. So one of them is the classical way we did until 15 years ago or 10 years ago. We give chemotherapy to a vein or a catheter. Chemotherapy travels all over the body to reach the eye through the ophthalmic artery. So the eye is maybe 1% of the whole tumor, the whole body of a child. So 99% of the rest of the body will get unnecessary chemotherapy. So a few years ago, starting with experiences in Japan and later in New York, we were the first group, one of the first groups in Europe to use this innovative treatment, which is intra-arterial chemotherapy. So what our team does here is, instead of giving the chemotherapy to the whole body with the hope that some part of it will reach the eye, we give it directly through the ophthalmic artery. So our specialists, that this needs a lot of training, a lot of experience, they catheterize, they put a catheter that goes directly to the ophthalmic artery. We give the chemotherapy there. So the amount of chemotherapy we give is very low to the body, but very high to the eye. So there are other ways that have been developed later, which are the intravitreous injection. So you can just inject the chemotherapy inside the eye, but this is useful only for a special complication that retinoblastoma has, which is what we call the vitreous seeding, when the tumor gets into the vitreous, which is a gel that is inside the eye. So we have also have some innovative treatments, like it says here, with Dr. Montero. We're going to go with it to describe them in greater detail, which are non-chemotherapy options, which are not going to cause any risk of the child in the long term or in the short term. And we are just right now trying to see if they are feasible and efficacious for this tumor. So sometimes we ask, sometimes our colleagues said, but if we really leave out systemic chemotherapy, are we not in danger? Because the tumor can disseminate to the outside the eye. And if we don't give chemotherapy outside the eye, what is going to happen? Is our child going to be at risk of the disseminated disease because we give intra-arterial chemotherapy or intravitreous chemotherapy? The answer is no. It has been proven clinically this does not happen. And also studies in our labs show that, in fact, the tumor disseminates through the optic nerve, which connects the eye to the brain. And intra-arterial chemotherapy reaches the optic nerve much more effectively compared to intravenous chemotherapy. So we are covering for fatal dissemination, which is CNS, central nervous system dissemination, much more effectively with intra-arterial chemotherapy compared to intravenous chemotherapy. So whenever it's available, there are quite few indications now of intravenous chemotherapy for treating retinoblastoma. So these are the advantages of intra-arterial chemotherapy. There are far better results for eye conservation this is more important with tumors when they are advanced or when they relapsed after systemic chemotherapy. There is no alopecia, so the hair doesn't fall, which is probably not such a big deal in small children, but it's still quite striking for parents. And it's not nice to see that your child loses her or his hair because of the treatment. Has a lower impact on quality of life because it has less associated infections. You have no catheters, no portacath, no transfusions, or very, very low risk of transfusion to be more precise. Less infections, and most importantly, like I show here, less impact in inducing secondary malignancies. So you are not going to pay the price in 20 to 30 years because of the decision of saving the eye. However, it has some disadvantages. Of course, if you give massive doses of chemotherapy to the eye, you are probably going to have more ocular side effects. So, and this can be severe. So anytime we have tumors that are less advanced, we sometimes prefer intravenous chemotherapy because it is successful. We can give maybe 1 or 2 or 3 cycles, and they will treat absolutely right the tumors without causing much toxicity in the short and in the long term. But for advanced eyes that have more visual problems, we usually take the risk because the results are much better in terms of conservation. And this is very important. In order to be effective with this treatment, you have to have a team that is highly qualified, has a lot of experience, and more especially so, is well equipped with current state-of-the-art technology. Because you might, if you use old technology for giving intra-arterial chemotherapy, you can increase also the risk of radiation to your patient. So these are some comments when you fight for life, when your child unfortunately is in danger because there's risk of the tumor is outside the eye, or the tumor is already outside the eye. It is very important to have a very careful evaluation of the disease dissemination as we do at St. Joan de Déu. We are leaders in genomic profiling and molecular biomarkers. We were the ones that first described this molecular pattern of extraocular retinoblastoma. And we also have another tool that is, our team has a great experience in immunotherapy for extraocular retinoblastoma, and we are the ones that are treating the first children in the world with this very promising therapy. So these are my introductory comments. So I look forward to receiving your questions, and I'd love to have the chance to answer them. So thank you very much for your attention.
Thank you very much, Dr. Chantada. Here we have some questions from our audience. First one, what is the best chemotherapy for orbital retinoblastoma?
Well, orbital, it's a great question. Orbital retinoblastoma occurs when, in the scenario I mentioned, that is when you fight for life. Orbital retinoblastoma is when the tumor is already outside the eye and it's now in the orbit. So it needs a multidisciplinary treatment, usually involving intravenous chemotherapy, surgery, and orbital radiation. These are the occasions that it is a life-threatening problem, so you need to be very aggressive in treatment. There are some groups that are trying to test intra-arterial chemotherapy also for orbital retinoblastoma, but the standard treatment, which is quite effective but toxic, is the one I mentioned with systemic chemotherapy, surgery, and orbital radiotherapy.
Thank you, doctor. The second question, management of late metastasis to tumor of retinoblastoma after 9 years.
Well, this is also a great question, and it is sometimes it's hard to tell if this is a late metastasis of retinoblastoma or a secondary tumor. So here is when you need those molecular markers that I showed you before. You need to be able to fully characterize that tumor, and so then you know if it is a second tumor or if it is a relapse of retinoblastoma. These cases can still be cured. They need also intensive treatment. As I mentioned, they are fighting for life, so you need intensive chemotherapy, usually radiation therapy, and in many instances, they will need also high-dose chemotherapy and autologous transplantation.
Thank you. Is there a study on the possible sequelae of applying intra-arterial chemotherapy?
I beg your pardon, I couldn't hear the first part, sorry.
Is there a study on the possible sequelae of applying intra-arterial chemotherapy?
I'm sorry, I still don't get you. The first part.
Is there a study on the possible sequelae of applying intra-arterial chemotherapy?
A study of the possible?
Sequelae.
Sequelae, okay, yes. Well, there are studies, you know, this technique has been applied for about a decade, maybe 12 years. So we don't know what happens in 20 or 30 years. It's still very early to know. So what we know so far is that the sequelae are not very important. They are only limited to the eye. And as I mentioned, probably they are related to the toxicity of intra-arterial chemotherapy to the eye. But there is no sequelae like fertility problems, for example, problems with audition, which are the ones that you see with systemic chemotherapy. So far, what we know is that there are very few sequelae.
Thank you so much, doctor. Sorry for my pronunciation. Thank you.
No, thank you. Thank you very much.
So let's welcome our next speaker today, Dr. Jaume Catala, who is our leading ophthalmologist with specialty in retinal disease. Welcome.
Hello, thank you very much for this invitation and this opportunity to talk with you. I'm going to share my screen. Okay, in this presentation, I'm going to talk about our experience with the conservative management of intraocular retinoblastoma in our center. Retinoblastoma is the most common pediatric intraocular tumor. It has a retinal origin and represents the second most common malignant tumor in children. The risk of developing retinoblastoma increases with parental age. We are going to comment on the differential aspects of our hospital in terms of diagnosis, treatment, and follow-up. We are working in a pilot universal neonatal screening to detect retinoblastoma and other ophthalmological pathology in the first days after birth. We have recently introduced the inbuilt OCT in the microscope to be able to detect preclinical lesions and recurrences and to assess the macular and foveal status of our patients. Regarding treatment, we will focus on the treatments to preserve the eyeball in those cases in which we can safely try it. When we consider treatment of any patient with cancer, and much more if it is about trying a conservative treatment in retinoblastoma, we have to be very clear about the order of the objectives. First of all, the life of the child, and to preserve it, we must adapt our strategy to the means at our disposal. Second, the preservation of the eyeball, as long as it allows good aesthetics and psychological health. Third, and whenever possible and safe, it is desirable to preserve visual function, be it central vision or peripheral vision, which is so important for mobility. And more recently, and above all, with the appearance of new treatments, which are very demanding both from the technical, family, and follow-up point of view, we must consider long-term health. It is what has been summarized with the phrase alive, with good vision, and without comorbidity. When we are doing intra-arterial through a femoral approach, a catheter is introduced up to the internal carotid artery and placed in the ostium of the ophthalmic artery. Once the correct location and arterial circulation are checked, the chemotherapy is injected. Between 1 and 6 cycles are performed every 3 to 4 weeks, depending on response to treatment, followed by local consolidation therapy. It is a very effective technique, as we can see in this 13-month-old girl with stage 2A intraocular tumor, group C, who was treated with 3 sessions of intra-arterial chemotherapy with melphalan, obtaining a very good tumor response, and after consolidation with thermotherapy and ruthenium brachytherapy, allowed a visual acuity of 0.6. But the conservative treatment of retinoblastoma does not end here. In cases with vitreous seeding, we generally complement intra-arterial chemotherapy with intravitreal chemotherapy, preferably topotecan. We always perform the treatment under surgical microscope and intraoperative OCT. Injection, as you will see here, are firstly in the anterior chamber. We take out the content of the eye to evaluate how it is affecting the anterior part of the eye, and then we perform the injection in the posterior part of the eye. Injections usually are scheduled every 1 to 2 weeks until seeds control. In selected cases with anterior chamber seeding in eyes with visual potential, we perform intracameral injection of topotecan combined with intravitreal injection. As in this patient who had a retinal tumor reactivation with vitreous and anterior chamber seeding. We perform at the same time the intracameral injection, as you can see here, of the topotecan, and then the intravitreal injection to treat both the anterior chamber and vitreous chamber seeding. After completing the treatment with combined intravitreal and intracameral chemo and thermotherapy, we have been following the patient for more than 3 years after treatment, and the patient maintains a vision of 0.9. One of the most important and complementary elements in the conservative treatment of retinoblastoma is the follow-up, both in the short and medium term and in the future long term. While a patient is in treatment, he will require checkups every 2 to 6 weeks until their disease is controlled, which is considered when they have been without recurrence or tumor reactivation for a year. This video shows the most common access in ophthalmic surgery cases through the ambulatory surgery unit. Although it is not an ophthalmological patient,
Hola, soy
access and
Miquel,
facilities
tengo
are the
7
same.
años y os contaré una experiencia que he vivido y que recordaré toda mi vida. Hace unas semanas fui al Hospital Sant Joan de una especie de calcetines verdes
Usually
que hay que
patients
usar para que el sitio al que íbamos estuviese muy limpio y libre de gérmenes. Mientras caminábamos por el pasillo, descubrí que todo era muy luminoso y estaba lleno de formas de animales diferentes y cometas de colores en el techo. Ah, y cuando llegué a mi box, pude poner mi nombre en la puerta bien grande. La verdad es que la espera no se me hizo nada aburrida. Casi me olvidé del hambre y del miedo que tenía antes de llegar. Me pasé todo el rato jugando y jugando. Resulta que hay payasos que entran y salen de los boxes y son capaces de divertirnos a los que la espera no se me hizo nada aburrida. Casi me olvidé del hambre y del miedo que tenía antes de llegar. Me pasé todo el rato jugando y jugando. Resulta que hay payasos que entran y salen de los boxes y son capaces de divertirnos a los más pequeños, pero también a los mayores. Además, están en la sala de juegos, donde puedes ponerte a dibujar y colorear. Luego, cuando vinieron a buscarme para operarme, también me acompañaron. Lo que más me gustó fue que mi madre estuvo conmigo hasta que me quedé dormido.
Usually
Ah,
parents
¿y
can get
sabéis qué
inside
descubrí por
the
el pasillo
operation
antes de
room at the
llegar?
beginning of
Pues que los
the
niños más
surgery
pequeños pueden
to
conducir
help
hasta el quirófano un coche teledirigido.
the children
Cuando me
be
desperté
quiet
de la
and
operación, estaba
confident
un poco
until they get
adormilado.
with
No me dolía
anesthesia.
nada y ya no tenía nada en el ombligo.
With all these techniques, the treatment of intraocular retinoblastoma achieves a 5-year survival of 97%. The percentage of preservation of the eyeball in stages T1 to T2A, it means groups A, B, and C, achieves 100%, and up to 90% of T2B stages, group D. The adverse effects of external radiation therapy, especially in the long term, make it advisable to avoid it. The risk of second tumors, already high in children with germline mutation, is multiplied by 10 to 30 after external radiotherapy. In the long-term follow-up, we must consider and improve the quality of life of our patients and think about the different options for genetic counseling and family planning for families and patients of legal age. In the future, we dream of promising results in the first patients treated with gene therapy, as Dr. Chantada already pointed, the emergence of liquid biopsy and its many possibilities, like the development of personalized treatments. And I do not want to fail to mention the increasingly necessary collaboration between hospitals and between countries to optimize resources, monitor patients between units on different continents, taking advantage of mobility and international cooperation despite the pandemic whose end is closer and closer. In conclusion, retinoblastoma is the most frequent malignant tumor in childhood, and early detection is key to increasing survival as well as the ocular preservation rate and better visual function. Intra-arterial, intravitreal, and intracameral chemotherapy has significantly increased the rate of ocular preservation. The retinoblastoma unit requires the coordinated work of a team of different professionals, from pediatricians, oncologists, ophthalmologists, interventional radiologists, anesthesists, geneticists, pathologists, nurses, and also researchers capable of curing patients and making new and better treatments come true. Collaboration between hospitals and between countries is unavoidable for the management of patients in a globalized world. Finally, we must not forget the long-term follow-up of patients and their families, including the health and personal spheres, to offer them the best possible quality of life. Thank you very much to all of you and to the entire team of the Pediatric Intraocular Tumor Unit of Sant Joan de Déu Hospital.
Thank you, doctor. Very lovely photo. We have some questions for you. After 3 interventions, the tumor is stable, but there are still many vitreous implants. In this case, are there any other methods of treatment besides eyeball injection?
The vitreous is the part of the eye that is scarcely vascularized. So in most cases, when there are active vitreocytes, the best way to treat them is injecting directly inside the vitreous. It can be either chemotherapy, traditional chemotherapy, or the new treatment with the virus that we usually treat them under direct injection inside the eye. In some cases, intra-arterial chemotherapy can reach also the vitreous, but the concentration of the substances we put into the eye aren't as good as when we use intravitreous injection.
Thank you. Another question. After treatment, the child is afraid of light when outdoor and closes his eyes. Is there any good ways to treat it?
When we treat retinoblastoma, we usually perform cryo or thermotherapy, and those techniques provoke scars in the retina. So these scars work as some kind of mirror that translates the light to the other parts of the eye. So what we do in these patients, we usually will recommend them the use of filters, special, usually Corning filters, that they are designed to protect the child from the photophobia without taking out the contrast of his vision.
Okay, another question. What is the likelihood of tumor recurrence after completion of localized treatment?
Sorry, can you repeat the question?
What's the likelihood of tumor recurrence after completion of localized treatment?
Well, the retinoblastoma is the only tumor that we cure without taking out the organ. So that's the reason because the follow-up is so important. These patients usually they have either recurrences or appearance of new tumors, especially in the first years after the initial treatment. So the recurrence and appearance of new tumors is very, very frequent, especially in the patients with bilateral or genetic mutation. So in those patients, follow-up is very important to treat these recurrences or new tumors when they are very small and they are still affordable for the local treatment.
Thank you so much, doctor, for your time. Thank you.
Thank you.
Our last speaker today is our leading researcher in our institution for the retinoblastoma, Dr. Montero Carcaboso, who is one of the main authors for the innovative virus therapy published on Science Translational Magazine, the one I was screenshot in my earlier PPT. Welcome, doctor.
Thanks very much. I would like to apologize in advance because we have construction works here at hospital related to the construction of the Pediatric Cancer Center Barcelona. So if there is any noise, I apologize for that. So I'm going to talk today about the treatment of retinoblastoma with the oncolytic adenovirus VCN01, and I will let you know about the scientific basis for this treatment and our first clinical experience. Why we need new treatments such as this? Why current treatments can fail? So first case is because some tumors, some patients, they will become resistant to therapies. So this is the case of a big tumor in which we applied the therapy, but after the end of the therapy, there was still some resistant tumor here. So in these cases, to save the life of the children, we need to enucleate, we need to remove the eye with surgery. This is one case in which we need another treatment for this resistant tumor. Second reason to improve treatments is because some treatments or some patients can get the retinal toxicity after treatment. In this case, as you can see here, this tumor disappeared completely after therapy, but the retina had some toxicity. For these cases, we have a vision loss. These experiences, we have them published in this article in 2014. And this is why we still want to improve treatments with alternative treatments, such as the one I'm going to explain today. What is the change we want to make to improve these difficulties we find? So first, we want to find highly selective treatments targeting only tumor cells. So we want the treatments to be toxic for the tumor, but non-toxic for the healthy retina. And we want these treatments to be other than chemotherapy. So the approach we decided to introduce here in the laboratory was to target the differential genes between retinoblastoma and normal cells. And which are these genes? So we know retinoblastoma tumor cells, they have a double alteration in the RB1 gene. However, the retinal cells do not have such double alteration of RB1. This is a big difference between both tumor and normal cells. So we have a new treatment, which is an adenovirus that will target only tumors with the double alterations in RB1. And this treatment has been developed by a company in Barcelona called VCN Biosciences. What is this treatment? The name is VCN-01, and this is an advanced generation adenovirus treatment. This is an electronic micrography picture of the adenovirus, which is a very small thing, as we all know. Into the adenovirus, the treatment developers at the VCN Biosciences, they modified the DNA. This is the DNA, and they did DNA engineering to make the virus more selective for the tumor and less toxic for the normal cells. So with these modifications, they developed the new treatment, and they have tested the treatment in several cancers. Actually, there is a worldwide clinical experience with VCN-01 in other cancers. And now we know it is safe because it has been given to adult patients in several clinical trial experiences. And we also know it has anti-tumor, anti-cancer activity or anti-cancer efficacy in these same clinical trials. Most importantly, this treatment, VCN-01, is applicable to several cancer indications because most cancers have RB1 deficient cells. And retinoblastoma, the tumor of the retina, is the one with the very good indication for this RB1 deficiency. That's why we decided to test this treatment in our institution. What is the approach we followed to develop this treatment? First, I have to say that we developed and patented this treatment at our center, and this is originally created here. We are the only institution in the world able to apply this treatment for retinoblastoma today. So at the Hospital Sant Joan de Déu, during many years, we have collected samples from patients in which the treatments failed. And from these samples, tumor samples, we were able to create several laboratory models, retinoblastoma models, to test this therapy with VCN-01 or any other therapy. In these very important preclinical models, we can test the anti-cancer activity of any treatment. We can find the best dose to have the therapeutic activity, and we can study the distribution of the treatment in the eye and in the tissues. After we finish all this preclinical work, we designed a phase 1 clinical trial to be able to treat future patients with retinoblastoma, in this case, chemo-resistant retinoblastoma. I would like to say that Sant Joan de Déu SJD Barcelona Hospital is one of the few institutions in Europe and in the world able to do all this clinical translation. How does VCN-01 work in retinoblastoma? So the treatment is injected into the vitreous. This green dot represents the virus that Dr. Catala, our colleague, will inject in our patients in which there is a resistant tumor. After days or weeks, the virus will replicate into the tumor, as you can see here in the green cells that are infected, and they are going to start to be killed by the viral activity. And finally, we can see the therapeutic action. In this case, as you can see here, this alive tumor disappeared and produced a dead tumor here. The best way for you to find details on this work is to go see our publication in Science Translational Medicine in year 2019, 2 years ago. I will show you here a few laboratory evidences that this treatment works. This is a tumor of a patient that we grew in mice. This is the appearance of a very alive retinoblastoma tumor in the mouse. After treatment, we see the tumor changes completely. This is a dead retinoblastoma tumor in which you can see much fewer number of cells compared to the original tumor. We performed this experiment several times. First, in the laboratory, we tested the efficacy in tumor cells, and we observed an efficacy, anti-cancer efficacy of 92% in 11 out of 12 patient-derived tumor cells. In mice, in tumor models established into the eyes of mice, we observed an anti-cancer efficacy of 100%. We tested 4 different models, and all of them had complete or activity or therapeutic activity, I want to say, of this treatment. Most importantly, we had to demonstrate that this treatment was superior to current treatment, to the available treatment. And indeed, it was superior. It was better than the current treatment in the mice. So with the VCN-01 treatment, we improved the outcome of the mice with intraocular retinoblastomas. And also, we observed that the treatment prevented the metastasis of the tumor from the eye to the mouse brain. This was an important result. For more details, again, go and check our publication in Science Translational Medicine. Who will potentially get a benefit from this study? So we want to give this treatment to children for which other treatments have failed, and for patients for which enucleation is the only recommended treatment. All these inclusion criteria are here available in this website, clinicaltrials.gov. What do patients receive in the study? So they will receive 2 injections of VCN-01 in their eye, separated by 2 weeks. They will receive 1 injection at day 1 and another injection at day 15. They will not receive chemotherapy. The virus will be the only treatment they will receive. What are the objectives of our study? So first, we want to maximize the efficacy of VCN-01 in patients with retinoblastoma. We want to determine the best and exact dosage for this treatment. We want to identify and to minimize adverse events. And we want to trace the fate of the treatment in other parts of the body. So far, we know the treatment is safe, has efficacy, and it stays in the eye, does not go out of the eye. What is the history of the study? So between 2013 and 2017, during 4 years, we performed the preclinical studies in mice and rabbits. The first patient was included in the phase 1 clinical trial year 2017. To 2021, so far, today, 4 patients have been treated with VCN-01. We still need to recruit more. So this is the current stage. We are recruiting patients for this phase 1 trial. This is the way to contact us if you have questions about our protocol. Fortunately, we have a success case with VCN-01. This is one of our patients. He was treated 2 years ago. He had only one eye remaining after the enucleation of the first eye, and the second eye was already resistant to all therapies. So he was a candidate for VCN-01 clinical study. This is the tumor in his eye. He had a very big and alive tumor in the vitreous. After we injected, Dr. Catala injected VCN-01, we observed a very nice response. We could apply other treatments, and we could even give more doses of the virus out of the clinical trial. This patient today conserves the eye, conserves the vision, and he has been free of disease for 2 years. We think this is an important result. With this happy ending, I would like to thank my collaborators, our collaborators and funders, with a special mention to the funders from my country, our country, Spain, and to remind ourselves the long-term mission of SJD, Barcelona Hospital, and the mission of our laboratory. For retinoblastoma patients, as Dr. Catala mentioned before, we want them alive. We want them to have good vision, and we want them healthy for their very long lives. For pediatric patients with cancer, with many other types of cancer, we want to develop more innovative treatments so we can save their lives or improve their lives. If you want more details, please check our website at Sant Joan de Déu. This is all I have to say in this presentation. I'm happy to take the questions. Thank you. Thanks very much for the attention.
Thank you, Doctor.
Thanks.
Thank you. So our audience have some questions for you. First one, is VCN-01 suitable for patients with repeated relapse after intervention, freezing, and other treatment methods showing to be ineffective? Is VCN-01 one of the choices or the best choice?
Okay, very good question. The answer is yes. VCN-01 clinical trial applies to patients with repeated relapses and patients for which all other treatments have failed, including all kinds of chemotherapy. So these patients are facing imminent enucleation, which is the surgical removal of the eye, as I said before. So the trial is a control experiment to evaluate whether this treatment, VCN-01, is safe and it is efficacious in these children. After we complete the trial in about 10 patients, we will evaluate the results and we will get the conclusions regarding the efficacy and the safety. According to the strict rules of the clinical research, before completing the trial, we cannot anticipate whether this will be a useful treatment for patients or will not be a useful treatment. But so far, we have results that are very hopeful. This is my message today.
Thank you. The second question, clinical trial inclusion and exclusion result of the experiment so far, and if it is looking positive?
Well, I replied partially to this question in the previous one. We analyze patients case by case, but the main inclusion criteria are: the first, patients have to need to have an active retinoblastoma tumor in one eye. Second, This active tumor is resistant or non-responsive after the use of all treatments available at the referral site of this patient. Third, enucleation is the only recommended treatment after the use of all treatments in the referral site. So the medical team at the referral site recommend enucleation for this patient. Fourth, the patient needs to be healthy regarding the kidneys, the liver, and the bone marrow. And the last one, the patient has to be older than 1 year old. So far, we are analyzing the data of the first patients that have received the treatment. The experience with the first 2 patients was promising, and we published the data in the Science Translational Medicine paper. And after these patients, as I showed in my slides, another patient saved his unique eye after responding well to treatment with the virus, with the adenovirus. Thanks.
Last one, are there any specific research ongoing for Ewing sarcoma or any other childhood solid tumor in your institution?
Yes, the answer is yes. For the most vulnerable patients with solid tumors, we have a research program called a Precision Oncology Program at the Pediatric Cancer Center, Barcelona. And this research program is a strategy for the accurate diagnosis and personalized treatment of solid tumors. The program applies to several techniques: whole genome profiling with the 3 most advanced techniques: next generation sequencing, DNA methylation, and cytogenomics. We analyze several features in the patient tumor, but most importantly, what we do is we integrate this information with laboratory research using the biopsy of the patient to create a tumor model, an avatar model in mice. We have recently published the experience to create 30 pediatric sarcoma tumor models, tumor avatars in the journal. This was published in the Journal of Pathology Clinical Research. Anyway, the final goal of all this research for Ewing sarcoma or for any other cancer, difficult cancer to treat, is to identify treatment targets and to test the new precision treatments for the disease in a personalized way.
Thank you so much, Doctor. Thank you for your time.
Thanks.
And all the questions of Q&A, we will select all of them and to have them answered at our website and WeChat account. Due to the time limit, we have to stop here today. But you know where to find us for any of individual specific patient inquiry. Due to the private data protection law here in Europe, we are unable to answer your question in a group chat. Please get in touch with our hospital individual patient manager together with necessary of your medical reports, and they will work with our medical team. Again, thank you for your time, and we apologize for being a little delayed today. Have a good evening, good morning, and a good afternoon. See you soon.